All right, then let's get started. Go ahead and share my screen with you. Okay, so down the rabbit hole, ideas for treating nerve pain when all else has failed. Disclosures, I am the owner of Revolutions Naturopathic, and my clinics host trainings on emergency medicine for functional practices, luxury IV therapies, and practice building retreats. I do have a financial interest in each of those endeavors. So the nervous system is extremely complicated. It can be difficult sometimes to pinpoint the source of nerve pain as well as the exact pathology affecting the nerve. So I'm hoping to send you home today with some diagnostic pearls that will help you treat those patients that just aren't responding to therapies that you rely upon to be tried and true. These are your non-responders. These are the people that, for all intents and purposes, should be getting results, but they just aren't. They tell us in medicine, when you hear hoofbeats, look for horses, not zebras. We're going to be talking about some things that may sound like zebras, but once you know to look for them, they become much more common than you would have thought. Migrating pain is tricky because your patient will report that sometimes one joint hurts more than another, and they can't pinpoint when or why this happens. This particular pathology that we're going to talk about is one that came to my attention because of personal experience. You notice the picture of the kayak in the bottom right corner, and I'm sure you're wondering, what does that have to do with anything? Well, I actually discovered how to treat this pathology due to personal experience. Bear with me because sometimes anecdotal stories will help you remember things later. So I was in Hawaii, and the group that I was with partied pretty late, and they were all hungover in the morning except for me and one other girl. So the two of us decided to get up and go rent a kayak. Well, we ended up in a cove and saw a calm spot behind a rock and decided to paddle over and take a look and take a picture. Well, as soon as we had the shot lined up, this huge 20-foot wave came over the rock, slammed us into the cliff behind us, and it wasn't a calm spot at all. It was an area that had been carved away by wave surges that happened about every 3 to 5 minutes. To make a long story short, we managed to get out, but after that accident, I had pain that would migrate from my sacroiliac joint to the groin, and then to the greater trochanter region. I had a clean CT, clean MRI, had an orthopedic surgeon offer nerve ablation of the sacroiliac joint. I treated myself with platelet-rich plasma for greater trochanteric bursitis. I chased this pain for 5 years and nothing helped until I happened to be sitting in a lecture hall and was reminded of a nerve that I hadn't even thought of since med school. I had thoracolumbar junction syndrome, and that was creating inflammation in Maine's nerve. This is very treatable using Prolotherapy and Ozone, and I'm going to show you how to do it. Other than through patient history, you can use the skin rolling test to replicate the pain in the iliac crest, which is the cluneal nerve, the inguinal canal, which is the inguinal nerve, or the greater trochanter, which is the lateral perforator nerve. So by rolling and tightening the skin on the normal side, the skin rolling test, or its German origin, the Kleberfeld test. The procedure is the patient lies prone with arms relaxed alongside the trunk. The examiner raises a fold of skin between the thumb and forefinger and rolls it along the trunk on the extremities, or perpendicular to the course of the dermatomes. The examiner compares both sides and states where the skin is rolled more heavily. So Maine's nerve has its root at the junction between T12 and L1. And this is where you want to target your injection on the symptomatic side. If you don't have an ultrasound machine and you're doing this via palpation, you want to find your landmark at the spinous process of the L1 vertebrae. You'll go 1 to 2 inches lateral and 1 to 2 centimeters superior to the L1 spinous process, and you're going to sink your needle until you hit bone. You'll inject a small amount of proliferative solution and then angle the needle slightly up to drop between the transverse processes of T12 and L1. Your patient should report that each of the 3 regions of pain will light up with each injection. So while you're infusing the solution, they're actually going to say they're feeling it traveling down to the area that reinstigates the pain. When your proliferative solution has hit its mark, you unscrew the syringe and then you'll screw on a syringe containing ozone. I usually start with about 10 to 16 gamma. It's a little bit much to try to go any higher than that for this type of injection because that nerve is just really going to be inflamed. And we'll talk a bit more about ozone later. The ozone is important because it'll perfuse down the nerve's sheath and provide oxygen to the nerve that's been damaged. You'll change your angle again to find the upper branch of the main nerve and repeat the process. 2 to 3 of these treatments, spaced 4 to 6 weeks apart, will permanently resolve this particular combination of migrating pain. Be sure while you're doing this that you're watching the lung margins and you don't angle your needle too far lateral because you really don't want to puncture a lung. Now, what do we do when the migrating pain isn't localized to one particular set of locations? These are the people who just hurt everywhere. You'll see a large number of these people misdiagnosed with fibromyalgia. The chiropractors in the room will recognize these people as the ones where adjustments don't give improvement or relief, and in some cases, adjustments can actually make the pain worse. You may not even know that this is the case because these people will just disappear and not come back in and not tell you that it got worse. So if your patient has a history of traumatic injury and adjusting isn't helping, they may have parasympathetic nerve signaling, which is a remnant memory post-traumatic injury. That's a mouthful. So I'm going to go into depth into what that means. So what's happening here is that the central nervous system is continuously receiving a fight or flight signal that never turned off once the trauma had passed. And every adjustment is being read as a new trauma. And this can be anything from a car accident to a dog attack. I've even seen pulling a muscle during a workout trigger this issue. When I'm talking to my patients about it, I describe the situation this way, and this kind of explains the 3 different children that you see in these pictures. If a toddler were crying and hysterical, i.e. the nerves sending this signal to the brain, pay attention to me, there's a problem, they need to be soothed and calmed down after whatever the incident was that set them off, i.e. the trauma. Now, most of us just go back to our normal workaday life after an incident like this, and we just kind of power through, which never gives the body that ability to slow down, compensate, and adjust. So with a simple neural prolotherapy treatment, it's possible to start soothing the nerves that are still in tantrum mode, even though the trauma has passed. However, just like an upset child, it's easy to set those nerves off again. So these treatments have to be done very close together so that you get this progression of the really, really upset nerve, the sort of calming down nerve, and then the nerve that is pouting but not going to get set off easily again. So this is your pattern of injection. I use a 30 gauge 3/16 inch needle, and I diffuse the solution over the areas where the nerve roots come out between the transverse processes. So what this does is you've got your formula over here on the right. The bicarbonate specifically acts on the GABA receptors. So acting on the GABA receptors, bicarbonate invariably mediates a depolarizing current under physiological conditions. So what this does is it calms down and shuts off that constant panic button feedback that the brain is receiving. You do not want to have people get adjusted while you're doing this work. You'll get further verification that you're on the right track because people that need this therapy won't jump or be reactive at all to these injections. If you have normal nerve signaling and are not in fight or flight mode, these injections will feel like bee stings, and your patients will need you to take lots of breaks. They'll kind of be coming off the table, and they'll be uncomfortable. But some people, the people that need this, tend to not be reactive at all. Some people that I've had will even report seeing flashbacks of their trauma during the treatment. After you do this, be really careful sitting people up and check their pupils before you let them stand. These people will kind of describe like a lightheadedness. And what that has to do with is that their brain no longer is hearing these constant panic buttons, and that quiet can kind of be disconcerting for people. So give them a little bit of time to sit and adjust. Also, it's really important to do these treatments within a day or two of each other. If you spread it out too far, anything can set them back off. A near miss on the road, someone sneaking up on them and scaring them. It's really, really important to keep that crying child on the path to being more and more calm. Also, they'll notice the first treatment, relief only lasts a few hours. Second treatment, the relief will last more like 24 hours to 72 hours, a few days. And then the third will last even longer. I personally like to check in about 10 days after the third treatment, just because you know, there's the potential for them to have been re-triggered and they might need one more treatment. Usually they don't, though. All right. So good news, once you've kind of peeled away that layer of the onion, you can focus on whatever injury is remaining and use your more common therapies. So a lot of times these people will have a concomitant injury that is residual from that trauma that truly is a soft tissue injury, or, you know, a joint that really needs some different kinds of attention. Okay, so we will circle back to other causes of migrating pain, but for now, let's talk about post-herpetic neuralgia. First things first, if the virus is still active, you need to shut down replication fast to mitigate more damage being done. If you aren't sure, it's better to treat as if it's active, since herpes viruses really never go away and they can resurge at any time. Lysine is great because it really has no maximum harmful dose, and it can be taken on an ongoing basis to mess up the capacity of the virus to complete its shell coat. So it works by taking the place of arginine in the construction process, making it impossible for the adult viral particle to inject its DNA into cells. This is a great combination listed here to interfere with replication. Major autohemotherapy is an IV therapy using ozone diffused into blood and then run through an ultraviolet blood irradiation machine to increase white blood cell production. It kills the viral particles. It's also hyperoxygenating to the blood to create kind of an autologous vaccine of sorts. For those of you who utilize IV therapies, I also gave you some research on high-dose IV vitamin C, as well as noting that IV alpha-lipoic acid and poly-MBA can be useful in repairing damage to the myelin sheath of the peripheral nerves, which we'll talk about more in depth when we get into the section on peripheral neuropathy. Here's some of that research, and there is more in later sections. Okay, so for those of you who are unfamiliar, neural prolotherapy can be done in localized patterns as well, and sometimes uses a 5% dextrose solution to stimulate neural regeneration. Major autohemotherapy is a great way to hyperoxygenate red blood cells, stimulating metabolism, and kickstarting that regenerative process. High-dose vitamin C is great for repairing collagen, really antimicrobial, antiviral, and really just a good overall addition if you can do it. I have some other therapies listed here. Each of the treatments on this slide really kind of require training of their own. And teaching you how to do these things in a 1-hour lecture, it really isn't realistic. But at least you have a starting point for some of the therapies you may want to pursue some more extensive training on. If your patient has migrating pain that isn't regional and not trauma-induced, make sure when you're taking your history that you keep this stuff in mind. There's a lot of denial about how widespread Lyme disease and the co-infections that go along with it is. However, if you're looking for it and start doing the appropriate testing, you'll see it way more frequently than you might expect. So migrating pain of infectious origin, worse for certain weather, but not related to an injury specifically or hardware, you know, joint replacements, screws, that type of thing. Worse during the full moon, that's Babesia or Bartonella. Those lovely buggies like to breed around the time of the full moon, so people will feel much worse during that time. Some women will even think that it's PMS related, so go ahead and check hormones too if they have this complaint, just in case. Oxygen starvation is a common complaint in these people. Hot swollen joints, deep fatigue that can look like fibromyalgia, interrupted sleep patterns. Don't use platelet-rich plasma on these people. Particularly in an encapsulated joint like the knee, if you inject PRP with spirochetes from the blood into the joint, they're going to have a party and you will end up with patients getting worse. Also, you don't really want to use prolotherapy with dextrose either, because some bugs will like it a little too much. So what do you use instead? In place of dextrose in your Prolo solution, I recommend vitamin C. It's a bit more burny on the front end of the injection, but the numbing portion of your solution should take care of that. Ozone is also great in these people. Not only does it oxygenate the tissue you inject it into, which not only increases metabolism and gives these people with oxygen starvation an extra boost to the injured area, but it also kills bugs, giving the immune system a better blueprint for what the white blood cells are looking for. Migrating pain of autoimmune origin. So what do we do when the pain is caused by the person's immune system attacking the joints and nerves? Diet is key. How much sugar are they consuming every day? Sugar is an inflammatory agent. I don't care what the cause of pain is. Sugar will absolutely make it worse. Do they have food sensitivities? Make sure you're checking IgG, because that's going to give you a clue about any delayed hypersensitivities. Personal anecdote, my food allergy test came back positive for avocados, and this is the IgG test. I did the whole remove it from your diet for a month and then load up to determine what the inflammatory reaction was, and nothing happened. So for years, I continued to eat avocados until about 5 years ago, I started doing aerial silks, the trapeze and there's the cloth and you climb up and all of that stuff. Anyway, I started doing aerial silks, and sure enough, avocado season rolled around and my hands got so arthritic that I couldn't climb. So if that precipitating event hadn't happened, I probably would have gotten into my 60s and had arthritis, but not known why. So those food sensitivity tests can be pretty valuable. You know, the lab companies themselves do a great job of helping you out if you run a test and you don't really understand what the results mean. Give them a call. They'll have a doctor call you and go through specific test results until you start to get really comfortable and really familiar with those tests. Check people for mold and pesticide exposure. Those can create inflammation, and check hormones. I mean, especially if the patient has a low platelet count. Oftentimes I find this pattern of low platelets, and then you check testosterone, and testosterone is low, and testosterone affects platelet activation. So testosterone is depleted in men trying to maintain a balance in toxic exposure, because testosterone also helps those gentlemen eliminate those toxins. So oftentimes too, what you'll see in families is mom and kids get sick, and then it takes dad a year or two later to get sick once his T runs out. If the person has Sjogren's, which is kind of a nerve pain with a cold component, you can use niacin to open up the circulation and in the peripheral tissues. And you can get them swishing with a glutamine to help with that membrane repair and the dry mouth that they get. And here's some research for you to look further into that. Next, we're going to be getting into some of the things that cause nerves to start getting fritzy. So mercury is really well known to be an extremely neurotoxic substance. Most people have exposure from metal amalgam tooth fillings and from bioaccumulation of mercury in fish that's higher up in the food chain. So this is kind of how it works. I'm going to show you a video a little bit later that'll go a little bit more in depth, but before you see that video, I kind of want you to get a conceptual understanding. So what happens is that mercury binds to the beta subunit of the actin molecule. So it basically creates a Lego that doesn't properly connect to its neighbor. So the neural fibril ends up with holes in it. And as we know, a nerve conducts its signal in a very similar way to an electrical cord. The myelin sheath is meant to keep the signal going in the right direction, just like the rubber on an electrical cord keeps the electrical signal moving. When the sheath is pockmarked by mercury, the signal gets fritzy and goes everywhere. You can't repair a nerve if there are molecules of mercury blocking the ability to connect. So the University of Calgary did a great study using snail brain tissue that shows how mercury just strips the myelin sheath away from neurofibrils. They did a great video on YouTube that explains the whole study. I'm going to show you right now.
How mercury causes brain neuron degeneration. Mercury has long been known to be a potent neurotoxic substance, whether it is inhaled or consumed in the diet as a food contaminant. Over the past 15 years, medical research laboratories have established that dental amalgam tooth fillings are a major contributor to mercury body burden. In 1997, a team of research scientists demonstrated that mercury vapor inhalation by animals produced a molecular lesion in brain protein metabolism, which was similar to a lesion seen in 80% of Alzheimer's diseased brains. Recently completed experiments by scientists at the University of Calgary's Faculty of Medicine now reveal, with direct visual evidence from brain neuron tissue cultures, how mercury ions actually alter the cell membrane structure of developing neurons. To better understand mercury's effect on the brain, let us first illustrate what brain neurons look like and how they grow. In this animation, we see 3 brain neurons growing in a tissue culture, each with a central cell body and numerous nerve-like processes. At the end of each nerve-like is a growth cone where structural proteins are assembled to form the cell membrane. 2 principal proteins involved in growth cone function are actin, which is responsible for the pulsating motion seen here, and tubulin, a major structural component of the nerve-like membrane. During normal cell growth, tubulin molecules link together end-to-end to form microtubules, which surround neurofibrils, another structural protein component of the neuronal axon. Shown here is the neurite of a live neuron isolated from snail brain tissue, displaying linear growth due to growth cone activity. It is important to note that growth cones in all animal species, ranging from snails to humans, have identical structural and behavioral characteristics, and use proteins of virtually identical composition. In this experiment, neurons also isolated from snail brain tissue were grown in culture for several days, after which very low concentrations of mercury were added to the culture medium for 20 minutes. Over the next 30 minutes, the neurite membrane underwent rapid degeneration, leaving behind the denuded neurofibrils seen here. In contrast, other heavy metals added at this same concentration, such as aluminum, lead, cadmium, and manganese, did not produce this effect. To understand how mercury causes this degeneration, let us return to our illustration. As mentioned before, tubulin proteins link together during normal cell growth to form the microtubules which support the neurite structure. When mercury ions are introduced into the culture medium, they infiltrate the cell and bind themselves to newly synthesized tubulin molecules. More specifically, the mercury ions attach themselves to the binding site reserved for guanosine triphosphate, or GTP, on the beta subunit of the affected tubulin molecules. Since bound GTP normally provides the energy which allows tubulin molecules to attach to one another, mercury ions bound to these sites prevent tubulin proteins from linking together. Consequently, the neurite's microtubules begin to disassemble into free tubulin molecules, leaving the neurite stripped of its supporting structure. Ultimately, both the developing neurite and its growth cone collapse, and some denuded neurofibrils form aggregates or tangles, as depicted here. Shown here is a neurite growth cone stained specifically for tubulin and actin, before and after mercury exposure. Note that the mercury has caused disintegration of tubulin microtubule structure. These new findings reveal important visual evidence as to how mercury causes neurodegeneration. More importantly, this study provides the first direct evidence that low-level mercury exposure is indeed a precipitating factor that can initiate this neurodegenerative process within the brain.
So this applies to peripheral nerves as well as brain neurons. That video has been a great tool for patient education for me, particularly for those patients who kind of have trouble remembering why it makes sense for them to do chelation. That's, you know, part of the pathology of the memory care thing. Anyway, we're not talking about that. In order to treat this, chelation therapy is essential if you want nerves to start repairing. As a side note, you'll also see that people who have pain from being overweight or pain related to being overweight, but they can only lose about 15 to 20 pounds before they start feeling terrible. Oftentimes they do better if they're detoxing while working on changing body composition. For more training on that, ACAM, American College for Advancement in Medicine, has a great chelation training, as well as IV nutritional therapy for physicians, IIV NTP. And I think A4M has one, but I don't know how good it is, so I can't attest to that. Okay. So I'm bringing up diabetic polyneuropathy because I found that some of the pathology in creating neuropathy in diabetics can sometimes be seen in idiopathic peripheral neuropathy as well. Clinically, I've seen some of the same therapies that have been proven for diabetic neuropathy to be just as effective for those idiopathic patients. And this is a really nice study here. So when the vasa nervorum becomes clogged, delivery of blood and nutrients and oxygen to the nerve becomes impaired, and normal metabolism, the removal of waste and the delivery of nutrients is then impacted. So I love this image because it looks at the efficacy of neuropathy treatments versus the popularity of neuropathy treatments. This is a nice image to keep in mind when you're looking for options and your patient has tried everything. Oh, here we go. So this is a good way to look at how some of those treatments shown in the previous slide actually work. So your C fibers are modulated by sympathetic input with spontaneous firing of different neurotransmitters to the dorsal root ganglia, the spinal cord, and the cerebral cortex. Your sympathetic blockers, like clonidine, and depletion of axonal substance P, used by the C fibers as their neurotransmitter, i.e. capsaicin, may improve pain. I don't love this option because it depletes nutrients needed to make substance P. And then the body just ends up making more, depleting more nutrients, and then you deplete more substance P, and it's just kind of a vicious cycle that doesn't really fix anything. A delta fibers are use sodium channels for their conduction, and agents that inhibit sodium exchange, such as your anti-epileptic drugs, your tricyclic antidepressants and insulin may ameliorate this form of pain pretty well. Anticonvulsants, carbamazepine, gabapentin, pregabalin, topiramate, potentially activity of gamma-aminobutyric acid, inhibit sodium and calcium channels, and inhibit N-methyl-D-aspartate receptors. And alpha-amino 3-hydroxy-5-methyl-4-isoxazole propionic acid receptors. Dextromethorphan blocks N-methyl-D-aspartate receptors in the spinal cord. Your tricyclic antidepressants, your selective serotonin reuptake inhibitors like fluoxetine, and your selective serotonin norepinephrine reuptake inhibitors inhibit serotonin and norepinephrine reuptake, enhancing their effect in endogenous pain inhibitory systems in the brain. These are definitely not my go-tos, but I think they bear mentioning. Tramadol hydrochloride is essential opioid analgesic. 5-HT indicates serotonin. AMPA indicates alpha-amino 3-hydroxyl-5-methyl-4-isoxazole propionic acid class of glutamate receptor. Your DRG indicates dorsal root ganglia. GABA indicates gamma-aminobutyric acid. NMDA indicates N-methyl-D-aspartate class of the glutamate receptor. SSNRI indicates selective serotonin norepinephrine reuptake inhibitor, and the SSRI is selective serotonin reuptake inhibitors. And your TCA is your tricyclic antidepressant. So that's this grouping. Okay, so pain symptoms in neuropathy significantly affect quality of life. Neuropathic pain therapy is challenging. However, I have seen quite a bit of success with this combination of nutrient replenishment. Supplementation with a combination of alpha-lipoic acid, DHA, vitamin C, and vitamin E have done wonders in my patients with diabetic peripheral neuropathy, as well as idiopathic peripheral neuropathy. As a matter of fact, high-dose IV alpha-lipoic acid has been first-line therapy for neuropathy for over 40 years. So this study showed that 75% of patients saw at least 75% improvement in peripheral neuropathy symptoms after 21 treatments of IV ALA. Remember, ALA depletes thiamine, so this is alpha-lipoic acid, depletes thiamine, so it's critical to supplement with thiamine at doses this high or you'll get major muscle cramping. It's not possible to get the same effect orally. It has to be done IV. I've had a ton of patients just say, hey, can I just take 600 milligrams of alpha-lipoic acid orally, and it just doesn't give the same results. When you bypass the gut and just go straight to the bloodstream, it's a major game changer. And finally, switching gears here, I thought that this was an important topic because it gets overlooked a lot. Let's talk about scars. So this is one of those things that kind of dances in and out of my practice. It's something that I treated a lot in my first few years of practice, and then I sort of forgot about it, and then I started treating again. And I had a 55-year-old female that I was working with on low back pain. And none of the usual therapies were working. And I didn't realize until we had been getting subpar results for a few treatments that she had had a mommy makeover. So the scars in her abdomen were restricting movement of her pelvis, causing her low back pain. So it's very important to evaluate scars because most people don't realize that they go deep and they're not just on the surface. Patients will forget to tell you about them. If a scar is entangled with a nerve or is attached to a bone restricting movement, breaking up that scar becomes mission critical to getting that patient out of pain. Now, sometimes that can be done with rolfing or hard massage, but oftentimes the best and quickest way to break it up is with scar therapy injections. So these are A very similar formula to Prolotherapy, but may often incorporate saline as a way to have a greater volume of solution. These are some images of before and after scars. As you can see, they're a lot softer. The collagen has started to be restored. They're smoother. And if you were to feel them, they would feel a lot less restrictive to the area. All right, let's get into some formula stuff. So I talked a lot about injections, and I think it's important to note that there are tons of options, but I'm going to share what I use most and am most familiar with. We can really end up going down a rabbit hole if we start talking about all of the potential ways you can formulate a prolotherapy solution. So what is prolotherapy? What does that mean? So proliferation is stimulated by injury. And just by the nature of an injection, you're going to injure tissue because your injectate has to create space for itself. This is one of the reasons in many cases that cortisone actually makes things worse. So you inject the cortisone, and if the cortisone doesn't do its job in decreasing inflammation, what it does do is it breaks the tissue apart to create space for itself, and then it shuts down proliferation and regranulation, which is key in healing any sort of damage to tissue. So you go ahead and you inject that cortisone, and then the cortisone, calms down the inflammation, gets rid of the pain for a few months, 6 months if you're lucky, or if it's one and done, then it really has resolved your issue. But if you have to go back in and do another cortisone injection, you're now injecting into tissue that has greater damage because of the cortisone itself creating space for itself. So you then inject it again and create even more damage. So your cortisone only lasts for half the time it lasted before, and so on and so forth, until finally you do a cortisone injection. It doesn't help at all, and your orthopedic surgeon then says that you are surgical because there's too much damage in whatever joint you injected to do anything but have surgery. The cool thing is that with prolotherapy, with proliferation therapy, what we're doing is we're stimulating inflammation, but we aren't shutting down that regenerative phase of regranulation. So that first 4 weeks after an injection, your body has kind of gotten this clue in that there's a new injury that it needs to work really hard to start repairing the damage of, and then you hit it again 4 weeks later and you restart that regranulation phase. And each time you inject a prolotherapy solution, theoretically, if you do it in the right place, you're getting more and more repair with each subsequent injection until finally you've gotten the tissue healed up to the point where it's not creating pain. Some of the things that I will use in my prolotherapy solution are listed here. I personally like lidocaine and bupivacaine better than procaine. I've had more people have allergic reactions to procaine. There are some people that are diehard procaine. It's kind of 6 of one, half dozen of another. They both work. 50% dextrose is used as your irritant. So what that's going to do is that's going to get in there, and those little sugar crystals are going to create bleeding and irritation in the area that's damaged. Usually this is really, really good for loose ligaments and tendons that are kind of creating pain because they're not holding together structurally well enough. And this is the specific ingredient that with those Lyme and those infectious disease cases that you would want to substitute your vitamin C in for. I like taurine. It's a great membrane transport protein. It helps things get into cells. L-carnitine is great for helping with muscle building. Methionine, inositol, and choline, which is what MIC stands for, is good for improving metabolism. If you think that there's any sort of methylation issue in that particular person, it just gives them a little bit of extra love. B12, I personally use methylcobalamin or hydroxycobalamin. The methylcobalamin doesn't quite sting as bad, but it depends on the compounding pharmacy that you get it from. B-complex really can be pretty stingy, so I don't use it very often. And the same with the vitamin C. I only use the vitamin C if I really need to with those Lyme or those cancer patients. Now, I did mention ozone a couple of times too, and I really want to give you guys some info into this absolute miracle gas. Ozone is concentrated from medical grade oxygen. It's run through an ozone generator, and the speed at which the oxygen is run through the generator determines what's called the gamma, or the concentration. So what happens is we're dissociating those little O2 molecules and we're cramming them back together as O3 molecules. And that triplet oxygen molecule is extremely unstable. So when you inject that into tissue, it immediately breaks apart into singlet oxygen ions. That breaking apart action has an antimicrobial effect. It also has a little bit of an analgesic effect. And because you're creating this single oxygen ion, it moves across cell membranes very easily and really kicks up metabolism, does a really great job of that. When I use ozone, what I'll do is I'll get my Prolotherapy injection placed, and then once that lidocaine and bupivacaine kind of start kicking in, what you can actually do is take a hemostat. So you've got the needle in the patient in the spot that it needs to be. Take a hemostat, you unscrew your syringe that had your Prolotherapy solution in it. You set that to the side, and then you have a syringe full of your ozone gas, and then you screw that onto the needle that's already placed. So that way you don't have to poke the patient twice. And then you inject that slowly. It's actually pretty cool to see it on an ultrasound machine. It diffuses across the tissue. It creates an artifact, so you can't see the tissue itself anymore, but you can see it pushing and moving the Prolotherapy or the platelet-rich plasma solution into all of the surrounding areas, and it really does give a better sort of broad spectrum treatment for people, and it steps up the game quite a bit. I would highly recommend getting separate training on ozone therapy, because once you get an ozone generator, it opens up a whole new world of insufflation and intravenous use and limb bagging, and it's a tool. It's a really, really wonderful tool that will open up your practice quite a bit. The scar therapy formulas are fairly similar to your Prolotherapy formulas. I like to use saline or lactated ringers to kind of beef it up if it's a large scar or there are lots of scars. As we know, you can overdose on the canes. So if you start getting to a point where you've got, a person who has a lot of things that need to happen, are wanting a lot of joints injected and also doing a lot of scar therapy, you want to be able to beef up the volume of your solution with something besides lidocaine, procaine, or bupivacaine. One other one that I forgot to mention is sometimes it's nice to put a little bit of DMSO or ketorolac in your Prolotherapy solutions. That can be a really nice addition for people. The scar therapy formulations, typically we're going to be using a 50% dextrose, and you're just threading things super, super shallow and breaking those up really well. I like the D5W or the 5% dextrose solution as well if you've got somebody who needs a little bit of that irritant, but may also have Lyme or cancer or something like that, and you really don't want a whole lot of their dextrose in there to break it up. And then platelet-rich plasma. There's a lot of people who will sell you very expensive kits and systems. I don't personally use any of those. And if you would like to, direct message me at some later date, exactly how I do my platelet extraction, I can share that with you. Essentially, platelet-rich plasma it's a blood draw. And then the blood is spun until you drop out the red blood cells, and then there's a fraction that has a lot of platelets in it in the middle, and then there's the top section that's platelet poor. And if you do these with these different systems, what it'll allow you to do is basically pour the water off of your plasma and retain your fibrinogen and your growth factors and your platelets. And what you're going to choose to use this stuff for is more your rips and tears. So rotator cuff tear, labrum tear, if there's actual, obvious tearing of any of the ligaments or tendons around any of the joints, this really creates a nice internal scab. And if you can put that plug of platelet-rich plasma right into that tear, you can basically allow that to knit back together, and it creates sort of like a natural glue that makes that tear smaller and smaller each time you do it. This one as well, you're going to do 4 weeks apart because you really want to give the full potential of that regranulation phase, of that first phase of repair, the opportunity to do everything it's going to do for your patient and give them what they need. And then last but not least, I just want to remind you guys, I know you know this, but there's a lot of excitement about prolotherapy, regenerative medicine, stem cells, exosomes, and that type of stuff. And I have seen quite a few patients that have gone to people who have decided to let the weight of their treatment fall on stem cells or PRP or exosomes or something like that, thinking that it's a miracle and it's going to just migrate to where it needs to go and do its thing. It does not matter what you're injecting if you inject it in the wrong spot. So make sure diagnostically that you really know and really understand what you're treating. I highly recommend learning ultrasound. It's a game changer when you can see into the soft tissue and know exactly what you're doing. It really does step up your game quite a bit. So good luck, everybody. This is me. If you need to get in touch with me and you need to ask any specific questions, this is where you find me.